Assalamu alaikum, everyone. Is my voice clear?
वालेकुम सलाम
वालेकुम
मैम।
सलाम।
So, I did try that I could wrap up the pediatric diffuse gliomas, especially the low grade today, but then I felt that it would make the session too speedy, so I decided to only cover one today. And we are going to have one more session this week, Thursday, to cover the pediatric diffuse gliomas, and then maybe we will wrap this up on Sunday. Friday is the radiology class by Dr. Itazaz, and I would really, really recommend all of you to attend it because he is brilliant at it. And he is really good at anatomy and then applying that anatomy to the radiology, which is, I think, we all need. So, without further ado, let's proceed. And today we are going to discuss a question that was interesting and it was raised in yesterday's session. I am not sure if Dr. Hussain is with us today because he was the one who brought this out. So, strategic management of low-grade gliomas which are eloquent. Which is better, subtotal resection or observation, especially when the patient is presenting with refractory pediatric epilepsy? So the question was, is STR justified for refractory seizures in eloquent low-grade gliomas when GTR is not possible? When we already know on the imaging that we won't be able to get the entire tumor out? Do we still subject the patient by a surgery, which is an invasive procedure, obviously, and involves a lot of risks? Or do we choose to observe and treat medically? So there were quite a few interesting aspects. For example, how many of you are familiar with this sign, the hand knob sign?
यस मैम।
Okay,
Yes,
so
ma'am.
this hand knob sign denotes that this is motor cortex, and this area most likely is the association motor cortex. I could not find a proper radiology which was depicting a low-grade glioma of pediatric origin involving the motor cortex. I really wanted to, but we can see that there is some extension going on here. This is the hand knob sign, this is the primary motor cortex, this is following here. This area is most likely association motor cortex. And we are just assuming that this is also involving the motor cortex as well. So we see this on the imaging, and patient has presented to us with refractory epilepsy. He is on two drugs already, and he is not responding. So what is the approach going to be? What if we observe? Has Dr. Hussain joined yet? I think no. Okay, that's okay. We will continue. So what if you observe? If we observe, there are going to be certain consequences because patient is having multiple seizures per day, maybe per month, and every seizure comes with cognitive decline. Every seizure comes with a risk of kindling. Kindling is when there are frequent seizures in the brain, and even the areas that are normal, they also with time develop abnormal wiring, which is the effect called kindling. Then there is the risk of sudden unexpected death in epilepsy, the SUDEP, which is rare but is still a real risk, especially when the patient has a medically refractory case. Then observation carries the risk of missing a wolf in sheep's clothing, and that is maybe the tumor is looking like a low-grade lesion on the imaging, but it is not. It might actually be a high-grade lesion. You can't be sure till you get a biopsy. So, is subtotal resection worth it? Well, the stats show that yes, they are. If you are giving gross total resection to the patient, then there is a very good chance that the patient will be seizure free, 80 to 90%. But even if you are offering subtotal resection to them, then there is a chance of seizure freedom in 50 to 60% of the patients. And sometimes, even if they are not completely free, the frequency of seizure does decrease. So, even a partial resection can reduce the seizure burden and improve the efficacy of AEDs that were previously ineffective. So what this is doing is subtotal resection can transform refractory epilepsy
सब
into a medically manageable epilepsy. Did somebody say something? Okay. Maybe someone's mic was on. So for a teenager, the ones in which you are choosing to observe and the ones in which you are choosing to do a subtotal resection. This might mean that the first group might have 10 seizures a month and the other group might have one seizure every 6 months. So, for a teenager, that is the difference between attending the school, socializing, potentially driving, versus living in constant medical surveillance. So, yes, subtotal resection does offer a decrease in seizure frequency along with an improved quality of life. So, in a 13-year-old or in a similar age group with refractory epilepsy, doing nothing is often the high risk choice. Moving on, we have this image today. Can somebody volunteer?
Assalamu alaikum, madam. I'm Dr. Sanaslim. Can I?
Yeah, Dr. Sinha, Assalamu alaikum. Yes, you can proceed.
Yes, madam. This is a CT brain axial section showing a hyperdense lesion in the right temporal lobe, well circumscribed and with some hypodense areas in the surroundings. Yes.
So, what do you think this hyperdensity is?
Uh, some calcified lesion,
Yeah, that's right. This is a calcified lesion. And what is the region of the brain? This is a temporal lesion, right?
yes,
So, what
temporal.
do you think this might be?
Calcified, some low grade uh, lesion.
Okay, so this is a different image. This is a different case. And if you see that these are axial sections, T1 weighted images, and I think you all can see my cursor. There is an iso to hypo intense lesion in the mesial temporal lobe on the right side, which you can see is ill-defined, and it is so far not involving the temporal horn of the lateral ventricle. There is no surrounding edema or mass effect, and the lesion appears to have involved the parahippocampal gyrus along the hippocampus as well. And if you see in the other section, this is also T1 weighted image, you can see that the temporal horn is spared. The ventricle is not involved. So this is the other imaging of the same case. This is a T2 weighted axial section of the same lesion. The lesion is in the corresponding location, the mesial temporal lobe, parahippocampal gyrus. You can see that it is hyperintense on T2, but the hyperintensity is not homogeneous. This is salt and pepper pattern. If you see it, you can see that there are black dots and then there are white dots. This is what a complete homogeneous hyperintensity looks like on T2. This here is salt and pepper pattern. And you do not see surrounding edema. And if you see the same lesion on the flare, this is axial section flare image. And we can see that there is still the salt and pepper pattern. Usually, the salt and pepper pattern is when the lesion is partly calcified. The areas of small calcifications appear as hypointense on T2 and flare, and the rest of the tumor is hyperintense. So, what we see is black and white dots pattern. This is post-contrast image, axial sections, and the lesion is not taking up any contrast whatsoever. So, this patient is a 17 years old. You did a biopsy. The biopsy comes as IDH wild type. What do you do? I think this question is so familiar that I'm sure none of you would fall in the trap. What do you do? Who is this in the chat? Samsung SMA065F. Who is this? Can you turn on your mic, please? Okay, maybe they don't want to. That's okay. So the patient is 17 years old and biopsy comes as IDH wild type. What do you do now? What do you ask your pathologist to do?
So,
Uh,
ma'am,
uh,
Yeah, Dr. Mustafa.
Yes, ma'am. 1p19 q co-deleted
Why?
because it mimics oligodendroglioma, ma'am.
Oligodendrogliomas are IDH wild type?
No, ma'am, they are IDH mutant.
Then what do you do in a 17 years old patient who is coming as IDH wild type because the pathologist ran the adult molecular panel? I was so sure
Yes,
that you people would not fall for this trap. You asked them to run the pediatric panel.
pediatric panel. That's 3 wild type, ma'am.
Yes, and whoever this is, Samsung SM, I would be very happy if you can turn on your mic because you are correct most of the time. So we would be happy to hear you. But it's okay if you don't want to volunteer. But yes, we run the pediatric panel in this patient. This is a 17 years old. He is still technically a child. And after we run the pediatric panel, we come across that this is, I have missed an L here, this is PLNTY. Polymorphous low-grade epithelial, neuroepithelial tumor of the young. This is PLNTY. This tumor is low-grade. It's a WHO grade 1 tumor, but it is IDH wild type. It has CD34 expression, BRAF V600E expression, and FGFR2 or 3 fusions. So even if it is IDH wild type, if either of these come as positive, then that grades this tumor as a low-grade WHO grade 1 tumor. So these are WHO grade 1 tumors. They are primarily seen in children and young adults. Median age is 17. Some books say that it is from 13 to 17. There is a long history of drug refractory epilepsy, and there is a very strong predilection for the temporal lobes. Prognosis is excellent. Obviously, these are grade 1 tumors. Surgical resection is typically curative for both the tumor and the epilepsy. So the radiology we have already seen, usually bubbly, sometimes solid cystic, cortical or subcortical masses, salt and pepper sign that we saw on T2 and FLAIR, and that is heterogeneous signal due to calcifications. Frequent coarse central calcification on CT can also be seen. So, because somebody brought out oligodendroglioma, yes, PLNTY and oligodendroglioma have some similarities when only the histopathology is run. On histopathology, you do see the chicken wire pattern, you see the fried egg appearance, both in the PLNTY and the oligodendroglioma. You also see calcifications, which are present in PLNTY and ODG both. They are both OLIG2 positive. They are both GFAP positive as well. GFAP positivity comes from being glial origin tumors. So, if you're only looking at the histology, it might be misleading or deceiving. But moving on, these are the differences. When you find the molecular panel of PLNTY, which is IDH wild type, and there are MAPK pathway alterations, BRAF V600E or FGFR2/3 fusions. When you find these, then that changes the tumor to a grade 1, which is highly epileptogenic. Also, oligodendrogliomas are epileptogenic as well. You also see these patients presenting with seizures, but they are typically present in adults, especially males, adult males, and they are grade 2 or grade 3. Being grade 2 means that there is some malignant potential. When a tumor is grade 1, it is usually indolent. Malignant dedifferentiation is extremely rare. So this is a comparison chart, and I have started sharing the PPTs as well. So any of you who want to access the comparisons, they can from the PPT. So this is the wrap up for PLNTY. It's a small tumor, but I kept the discussion short because I really wanted to touch up on yesterday's questions. We have discussed one, the subtotal resection versus the observation, and there were two more interesting questions. One was whether ECoG is still useful while patient is preloaded with anti-epileptic drugs. I'm regretting that Dr. Hussain is not here today because these were really his questions, and I was genuinely impressed by the line of thought. So what happens is, what is ECoG? Can somebody volunteer?
Electrocorticography, corticograph.
Yes, what does it do?
After opening the dura, we place bipolar-like electrode on the
On the
giving current
cortex, yes.
like this one, and uh, 5 milliampere current, and slowly increase it and look at the response to localize either the motor cortex or the sensory cortex
No,
or a
ECoG,
language
yes, ECoG can be used, but ECoG is mainly used to detect what?
language area. Ma'am?
Yeah, ECoG is used to detect the interictal spikes, the interictal irritative signals, which are arising from epileptogenic areas. Okay, somebody is writing, it's the same person. I am very, very curious who this is. Can you just write your name in the chat box, even if you can't turn on the mic? Okay. Oh, Dr. Fatma Javed, I am so happy to have you with me. So, ECoG is used to mark out the epileptogenic regions on the cortex. And how different it is from the EEG. EEG is not as accurate. ECoG is very accurate, down to 1 mm accuracy. And the question was that if the patient is preloaded with anti-epileptic drugs or whatever agents we are using, is ECoG still useful? AEDs raise the seizure threshold, yes, but they rarely eliminate the underlying interictal spikes that ECoG detects. So what happens is there is one seizure and there is another seizure, and in between them, these are the abnormal electric discharges, which are called interictal spikes. This is what the ECoG originally detects. Okay, so even if the patient is on multiple medications, the irritative zone is not going anywhere. It is going to remain electrically abnormal. And that is what the ECoG is going to pick during surgery. So the other question was, has ECoG got any use during a perioperative seizure? Because we know that while we are mapping a patient, when we are using cortical mapping, there is a small chance of patient developing a seizure during the surgery. So what ECoG does is, it works as a circuit breaker. It is used as both a diagnostic tool and a safety monitor during a seizure in the OR. For example, if there is a spontaneous seizure, ECoG is going to capture the exact location, and that exact location is called seizure onset zone. So what happens is, God forbid, your patient started seizing on the table, and ECoG pointed out the SOZ. When that happens, that's like hitting a gold mine, because yes, there is going to be some post-op complications due to the seizures, but you got where the problem was. The problem was pinpointed, and ECoG is going to detect that particular space very accurately. And what ends up happening is, if you resect that focus, patient is going to have a very good post-op prognosis. Am I clear, or is this all flying over your heads? Because this is neurophysiology. This is technically not what should have been discussed, but these were interesting questions, so I wanted to.
No, ma'am. It's very good that you have discussed this, and it's amazing. It's a new concept, and it's really good. Thank you.
Okay, I'm glad that it's working so far. So moving on, what happens is, for example, a patient seizes on the table. What ECoG does is, it identifies the abnormal discharges, and it points us to the exact location, and we take the exact location out. That's one mechanism. The other mechanism is, sometimes during speech or motor mapping, there are subclinical mini seizures. We all know that MEPs come with a problem of peroperative seizures, right? So what ECoG does is, it catches these mini seizures, it gives us an early warning. And when we get an early warning that, oh, the patient might start to seize, we stop the mapping, whatever mapping we are doing, we stop that. And then we do have the time to either intervene pharmacologically, we can load the patient with antiepileptics, or we can use the chilled saline to calm the brain down. So it ends up serving as a circuit breaker. And The last question from the yesterday's session was post-operative EEG. Why are we doing it at 3 months? Why not before? And I think why not after is also a valid question. Why the insistence on 3 months? 3 months is the diagnostic sweet spot, and I think I did answer it vaguely yesterday, but I did not want to take chances. So I went up and read on it. What happens is if you get an EEG too early, there is going to be a lot of noise from a healing brain because the brain went through a trauma. Yes, the trauma was iatrogenic. Yes, we chose it. It was a surgery. It was a therapeutic procedure. But the brain does not know that it's a therapeutic procedure. For the brain, it is still a trauma, right? So what happens is if you get an EEG too early, you're going to get a lot of noise from the healing tissue. That's one thing. Also, the craniotomy removes the physical barrier for some time, and that leads to EEG picking up higher signals because the barrier was breached. Because of the breach of barrier, the EEG is going to pick up signals on a higher amplitude, and that higher amplitude can easily be mistaken for pathological spikes or sharp waves. So basically, an EEG which is done too early, what it does is it picks up false positives. And I think I have already discussed the post-surgical irritability, that the brain is going through healing. There is edema, there is local inflammation, metabolic shifts, and there are temporary epileptiform discharges which have no use in the long-term prediction of patients' freedom from the seizures. So what happens is, if you do it later than 3 months, there are a few risks involved in it as well. If you delay the EEG, patient might develop seizures while we are waiting for the EEG, or we might miss an early epileptogenic focus. And because we chose to do EEG far later in the natural history, the epileptogenic focus, it became permanent because this is all circuitry, right? There is electrical circuitry that is going on in the brain. So 3 months is the sweet spot. This is what the literature recommends. Okay, it's the right time. There are very low chances of getting false positives, and the yield of detecting the right places, the right semi-resections is also higher. So as I said, if you do it early on, within the first 7 to 30 days, there's going to be a very poor predictive value, which is a lot of false positives. I think that's it for today. That's a wrap. Any feedback, any questions, they're welcome. I will try to wrap up pediatric gliomas on Thursday and Sunday, inshallah, and Friday is the radiology session. Any questions?
Yes, ma'am. I have a question. Will
Okay.
these session include anatomy lectures as well, or not just about tumor and tumor?
I am not sure about anatomy. Maybe we can plan something later on because I initially thought of this as a 3 month project where we can do 5 days or 6 days a week and brief sessions because if it's brief, it's easier to maintain the attention span. Anatomy, let's see. Let's see. We can plan something after we wrap this one up. For the first 3 months, I'm planning to only cover the pathologies. After pediatric gliomas, we are going to do the ependymomas and medulloblastomas, and maybe a week on meningiomas because meningiomas are huge. There are a lot of them, and all of them demand separate attention. So let's see where this ends up. And maybe when we are done with these 3 months, we might start anatomy from Rotan or something.
Okay, ma'am. Thank you so much, ma'am. If you have wrote on videos, please do share a link of them because I couldn't find it online.
Oh, there is a playlist, but it has only a few of the lectures, not all. Okay, everyone, no questions? So let's wrap this up. Thank you so much.
Thank you, ma'am. Thank you.